Hello everyone, welcome to this talk titled VVOI, a trick for collapse. What we need to know regarding collapse is that you could use different terminologies. Atelectasis equals collapse equals volume loss. And any of these terminologies could either be used with partial or complete volume loss or atelectasis. What we're talking about today is actually the complete lobar collapse, which is extremely important since you have different etiologies for such collapse, but the most concerning one would be that of a cancer obstructing an airway and leading to subsequent collapse of the lobe. Now, collapse is not easy on all cases. For an expert eye, you'd look for that, you'd most likely see it. However, for beginners, it might be very difficult to detect severe or long-standing collapse. And that's why I created this kind of trick for us to use as a hand motion trick to detect collapse on chest radiographs. So the details of this trick depends on knowing important anatomical landmarks. These are 4 landmarks starting with the position of the hemidiaphragms, the position of the Hila, the position of the heart, and the position of the minor fissure. Let's start by the first anatomical landmark, which is the hemidiaphragm. Now, in normal patients, the right hemidiaphragm is higher than the left in about 90% of the cases. And the difference between the right and left is about 1 to 3 centimeters, or another way to remember that is about half an intercostal space. In about 7% of normal patients, both hemidiaphragms may be at the same level. In the remaining 3%, the left hemidiaphragm may be higher, and again, this should not exceed 1 to 3 centimeters when compared to the other side. To know the normal position of the hemidiaphragms, you have to count the ribs on the right side. And a right hemidiaphragm is usually between the 5th and 7th anterior rib and at the level of the 9th or 10th posterior rib. Please note that these levels vary according to the patient's position. So if you take the X-ray in a supine position, that's different than taking it when the patient is standing. And the level of the hemidiaphragm would vary according to the patient's inspiration or expiration. The better the patient breathes in, the lower the hemidiaphragm. The more expiratory the scan is, the higher the position of the hemidiaphragm. And this brings us to the first hand motion trick. This is a simple hand motion that is created for us to remember the normal position of the hemidiaphragms. This is what I call the victory sign, and that's because you create a V with your index and middle finger, where the index points to the higher right hemidiaphragm and the hand is tilted in a way that the middle finger points to the left hemidiaphragm. So how do we interpret the first hand motion sign, our first victory sign? Let's say you do the hand motion and you notice that there is exaggeration of the tilt in a clockwise fashion. That could mean that the right hemidiaphragm is much higher than normal compared to the left, and it could mean that there is volume loss on the right side, such as a right upper lobe collapse, pulling everything on the right side, including a right hemidiaphragm that appears higher. The appearance may be the opposite if you have a counterclockwise change of your tilt. That could mean that the left hemidiaphragm is higher from a collapse on the left side that is pulling everything upwards as well. Now, when you look at this motion alone, it does not mean anything. You need to combine this motion with the next motions that we're going to talk about. And you also need to keep in mind some pitfalls. First of all, we've mentioned that the position of the hemidiaphragm may change even in normal patients according to the way you acquire the film, in a supine versus erect, for example. And it also changes with respiration. Remember that a change in the position of any of the hemidiaphragms could be due to other causes, not only collapse. For example, you have subdiaphragmatic causes, let's say hepatic enlargement pushing the right hemidiaphragm upwards. You could have diaphragmatic causes such as phrenic nerve paralysis, and you could have supradiaphragmatic causes, for example, fibrosis that tethers the hemidiaphragm upwards, or a pleural effusion that mimics an elevation of the hemidiaphragm. One thing to keep in mind as well is that this sign wouldn't be that effective with right middle lobe collapse. You would not see it since the right middle lobe is a small lobe which would not change much in the position of the hemidiaphragms when it collapses, and it could be very difficult to detect with cases of right upper lobe collapse. Now let's go to the second anatomical landmark, which is the position of the hilum. Compared to the hemidiaphragms, the hila are the opposite. In normal patients, the left hilum is higher than the right hilum in 97% of the cases. And normally, the left hilum is higher by about 2.5 centimeters compared to the right hilum, or you could easily detect that on a chest radiograph by using a finger breadth. Now, in the remaining 3% of the cases, both hila may appear at the same level. However, remember that it's never normal for the opposite to occur. It's never normal for the right hilum to be higher than the left. Now, this is the basis for our second V, or what we call the second victory sign. Again, you create a V by your index and middle fingers. However, the tilt would be the opposite, where your middle finger points to the higher left hilum and the index finger points to the lower right hilum. So this is your second victory sign. How to interpret this sign? If you do the hand motion to try to assess the normal position of the hila, and notice that the tilt is exaggerated counterclockwise, this would mean that either the left hilum is elevated from a left upper lobe collapse, or the right hilum is depressed from a right lower lobe collapse. And doing the hand motion trick and getting the opposite results, where your tilt changes to a clockwise position, this could mean the opposite, meaning that the left hilum may be depressed from a left lower lobe collapse, or the right hilum may be elevated from a right upper lobe collapse. Notice if you combine this hand motion with the first one, you'd actually know which lobe is collapsed. One thing to remember from this anatomical landmark is that the right hilum should never be higher than the left hilum. Now to the third anatomical landmark, which is the heart. It's easy. In a normal patient, 2/3 of the cardiac shadow should be located to the left of the midline. For us to remember that, we will use the third hand motion trick, which you could call the O sign or the perfection sign. You create a circle with your hand, and you place that circle on the left side of the heart. Only 2/3 of the cardiac shadow should fill that circle. If it's filled by more or less, and we'll see examples, that means that something's abnormal. So your third motion is called the perfection sign. So how to read this? If you try doing the circle and more than 2/3 of the heart is filling the circle, that means that the cardiac shadow is shifted to the left side, and that tells you that there is volume loss on the left. If the opposite occurs, meaning that the heart is shifted to the right side and less than 2/3 of the cardiac shadow is filling the circle that you placed on the left, that means that there is a right-sided volume loss or collapse. The pitfalls to keep in mind is that the patient's rotation would affect the way you see the heart. Rotated patients to the right or left might give you a misinterpretation of a shifted heart, so keep an eye on technique. And remember that the right middle lobe is a small lobe, so if it collapses, you wouldn't expect to see much shift of the cardiac shadow to the right side. Now to the fourth and final anatomical landmark, which is a landmark that's dedicated to the position of the minor fissure on the right side. The minor fissure is only seen in about 50 to 80% of normal frontal chest radiographs. And the normal location of the minor fissure is at the level of the right anterior fourth rib or the angle of the right sixth rib. To detect that, we created the eye, where you'll look for the fissure if you could see it and see if it actually is elevated or depressed, and that's what I call the number 1 sign. So how do you read this? If the fissure is elevated, that means that you have right upper lobe collapse. If the fissure is depressed, that means that you have right middle or lower lobe collapse. The pitfalls are you don't always see this fissure, so it might be useful if you see it, but if you don't, you're going to look for something else. Here's an overview of the VVOI hand motion trick. The first landmark is the hemidiaphragms. The right is typically higher than the left in most patients. The second hand motion trick, or the second victory sign, is dedicated for the position of the hilum, where the left is usually higher than the right. The third motion sign is detecting the position of the heart. So 2/3 of the heart should be on the left of the midline, while 1/3 should be on the right. And the final and fourth hand motion sign is the number 1 sign, where you try to detect the location of the minor fissure. Let's go to a few examples. So here's an example from an old radiograph, but this is a good one. If you try to do the first hand motion sign, you'll notice that there might be minimal elevation of the right hemidiaphragm compared to the left. Now, the second hand motion sign is very abnormal. The hilar position is reversed. Remember that the left hilum should be higher than the right. Here it's the opposite. The right hilum is higher than the left. In cases where the hilar opacity is difficult to appreciate, try to check for the bronchi, since these are air-filled columns that are easier to detect. Now, what about the perfection sign for assessing the cardiac position? This is something that you cannot use here since the patient is rotated. And finally, using the number 1 sign to check for the minor fissure, you notice that the fissure is elevated all the way up. This is because of a severe form of right upper lobe collapse. As I said, this is a tough case, and you might not think that this is the edge of the fissure. Instead, this could be normal right paratracheal opacity. So putting everything together here, you'd at least suspect the presence of this difficult right upper lobe collapse. Now to another example. You'll notice that there is an ill-defined opacity that projects over the left upper lung. Applying the first victory sign, or the first hand motion trick, you'll notice that this is reversed with a left hemidiaphragm that's higher than the right. Applying the second victory sign, you'll notice that the normal tilt is exaggerated counterclockwise, meaning that the left hilum is in a higher position than normal. So putting these two signs together, you'll know that there is a left upper lobe collapse. To confirm that, let's check the position of the heart, and most of the cardiac shadow is on the left side. So this is consistent with your findings of a left-sided volume loss. If you try to apply the number 1 sign, it's not applicable here since all the findings are on the left and you don't need to look for the minor fissure. All these are consistent with a left upper lobe collapse. Now for a third example, applying the first hand motion, the first victory sign, to assess the hemidiaphragmatic location, you notice that the right hemidiaphragm is minimally exaggerated. It's a tough call here, so let's look at the second victory sign. You'll also suspect that there is exaggeration of the counterclockwise, meaning that either the left hilum is elevated or the right hilum is depressed. Since you're suspecting that the right hemidiaphragm is elevated from the start, this tells you that the right hilum is likely depressed and everything is pointing towards a right lower lobe collapse. Now, if you check the heart using the perfection sign, you'll notice that about a half of the cardiac shadow is to the left of the midline and the other half is to the right of the midline. meaning that there is some shift to the right side. Again, this confirms that there is right-sided volume loss. The minor fissure is in its normal location, so the right middle lobe is not affected. All these features are consistent with a right lower lobe collapse. This is the opacity in the retrocardiac region from the collapsed right lower lobe. This here is not the hilum, this is an additional opacity, which makes everything difficult. And this turned out to be a squamous cell carcinoma, as you see here, compressing on the right lower lobe bronchus and leading to right lower lobe collapse. Another example here. This is an X-ray on a sick patient in the ICU who has an endotracheal tube. Trying the first landmark, you'd at least suspect that the left hemidiaphragm is in a higher position than normal. Trying the second hand motion trick, although it's a difficult thing to detect, there is reversal of the tilt, meaning that there is an abnormal clockwise tilt of the hand motion sign here, denoting that either the left hilum is depressed or the right hilum is elevated. Since you're suspecting that the left hemidiaphragm is abnormal, that tells you that it's likely that the left hilum is depressed. If the hilum is difficult to detect, as we mentioned, try to check the tracheal and bronchial airway columns. Now, almost all of the cardiac shadow is to the left side, another thing that confirms the volume loss on the left. The position of the minor fissure is not applicable. If you put everything together, this is pointing towards a left lower lobe collapse. Now to a final example. The first hand motion trick is maintained, so the right hemidiaphragm is in a normal higher position than the left. The second hand motion trick might lead you to suspect some slight exaggeration of the counterclockwise tilt, which, as we always said, could be due to elevation of the left hilum or depression of the right hilum. The cardiac position is in its normal location, where 2/3 of the cardiac shadow is to the left of the midline and 1/3 is to the right. And you cannot see the minor fissure, so it's not applicable. There's this L-defined opacity that obscures part of the right cardiac border. And the question is this pneumonia, is this volume loss, or is it something else? Here the lateral is of utmost importance. The lateral radiograph, although still difficult, shows a clear abnormality that you see here. This is a band-like opacity that is well defined inferiorly by the major fissure and that points to the hilum. This was a case of right middle lobe collapse. From this case, you learned that right middle lobe collapse is not really associated with lots of structural shifting, and that's why it's a difficult collapse to detect. If you don't want to miss it, make sure to look at the lateral chest radiograph. Now, what are the take-home points from this lecture? First, lobar collapse is a very important entity. Sometimes it's easy and sometimes it's more difficult. This could be missed if the collapse is difficult, severe, or long-standing. You need to know your anatomical landmarks and check for them on every single chest radiograph you look at, namely the right hemidiaphragm is higher than the left hilum is higher than the right, 2/3 of the cardiac shadow should be to the left of the midline, and the minor fissure should be in its normal location when seen. We tried to apply the trick on multiple examples of various types of lobar collapse. And one thing I need you to remember is that there are pitfalls, so don't use this hand motion trick on its own. You have to look for other things such as assessing for the technique, if the patient is rotated, the degree of inspiration or expiration, and comparison with other films, in addition to correlating whatever you see with the clinical information. If you want to read about this, you could check our article in the Canadian Association of Radiologists journal. And at the end, I would like to thank you for watching this lecture, but please remember to support us by following us on Twitter, Snapchat, Facebook, or Instagram. Also remember to check our Radiology Bits channel. We have more than 50 clips now, so support us by liking and sharing our videos. And you could also follow our products on our Radiology Bits Gumroad page. where you could have updates on our products. Again, at the end, I would like to thank you for watching us and see you with more lectures in the future.